So these are the steps of the inspired spine OLLIF. Patient is in prone. I put the lateral machine going above and AP machine coming from bottom up. Up is the X-ray source, bottom is the camera. And in the lateral, I adjusted that you see the end plates very clearly. In the AP, you have to put the spinal process in the middle of two pedicles. So you have a true AP for that level. It doesn't matter if it's not perpendicular to the disc, but you have to be able to see the trajectory of the disc. Even if patient has previous scars and so on, I always get a true AP and mark it in the AP. And then I get the trajectory of the disc. And then on the lateral, when the camera is up, the X-ray source is down, I use the elasticity of the wire itself and mark the middle of the disc of the level. The end plates are well visible. I'm in the lateral view. I'm in the middle of the disc. I mark it. I go to the here where patient's direction of the skin changes, goes from horizontal to vertical, mark this, and then take that, transfer this distance to the midline, to the continuation of the same line. It may align or may not align with that line that you just draw. So from here to here, so practically you have two lines, that's entry point. Upper one closer to midline, let you go more steep. Bottom one, let you go more laterally. And even if you can come a little lower, you can actually perform a direct lateral with this instrumentation, practically prone lateral with this instrumentation. But then once you have marked, you have your entry point. Then at the entry point, you go with the probe. Patient has to have 4 twitches, and you stimulate at 3 milliamp, and you go at the 45-degree angle to approach the Cambine triangle. And I think even before that, I put a Jamshidi in, get some bone marrow. I get the first 5 cc of each bone from bone marrow. After that, what you get is blood and not bone marrow. And literally, I mix it with my tricalcium phosphate, which has the consistency that works the best. We cut it usually in strips, 4 strips out of this, and that enables us to soak it well. After 3 to 5 minutes, you get the best attachment of the material, and that's the best consistency to work with. But then after we are done with this part, literally what we do is approach the disc at 45 degree. Can you see if it comes out well? We approach the Cambine triangle from our approach at 45 degree, and we stimulate at 3 milliamp. I aim for the pedicle of the upper level, the pedicle of the lower level, and at this angle, and then I drop on the top of the pedicle. I drop on the top of the pedicle here to the Cambine triangle, and then once I'm there, I use higher stimulation, 4 milliamp. At that point, you have to keep that space by putting the sleeve down. The sleeve goes down, and then I poke it. You have to get the X-rays, make sure that this doesn't move. But then I use the pokey part of the K-wire, and I poke it inside of the disc, and then practically I created the path from the skin to the disc. Now, once I have that path, does it come out here right now?
Yep, you're centered and everything.
Good, is it good? So once I have
Go ahead.
I have the pad. No, I can move this around. Put it down. That
Sure.
stabilize that, and I move this around. Where should I move it to? Here.
The problem is the angle. You're not quite high enough to see there.
Maybe you can turn it a little bit like this and see it.
Yeah. Okay. So once the K-wire is in place, the first step is the dilation, and with the dilation. These are the perks of each of the instrument. So the dilation goes with this. You are going to go through the skin, all right, but then the fascia will give you resistance. This is one of the first perks. If you try to force it, you may bend the K-wire. But what I do is let's just take a hammer. I just hammer it through the fascia or cut a slit. Don't fight the fascia, otherwise you may bend the K-wire. And then you have to start it all over. But then I massage it like this, roll it in, and go to the Cambin triangle. Once I'm in the Cambin triangle there, under X-ray I see, I make sure that my K-wire is not passing the midline in the APN lateral. If I need to take it out, this is the second perk. To fine control this, you can try to pull it down and then all of a sudden you're completely out. Look at, I wrap my finger around the grip here. Then I use a coker. I put the coker on my finger and look at that here now. I can now very controlled push it up and down. Okay, so that gives you a really good control of controlling the K-wire, that you don't all of a sudden jump out. But then once you have it in the proper place, and literally the dilator is in the right place, the dilator tip should pass the midline. Sometimes I go even to the other side and I break the osteophyte if needed. Then at that point, actually, the K-wire can come out, the handles come out. Now the tube goes in. Now this is another perk. Make sure that it's not overused. That make sure that the tips of this is truly smooth. If like for whatever reason that it's chipped or it has a corner, sharp corner, that is where what you are going to pass through next to the nerve root. And just make sure that this is truly like, when you walk it here, this is smooth. If you walk it through your finger now, Mitch, walk it through your finger, you feel that it is not smooth. You see that there? Because this is our demonstration tool, obviously. But you feel that should be smooth. Another perk, okay? So then you go in, again, massage it, and until you pass the fascia, you pass the whatever tissue is there. Once you are on the hard surface, you can either use this and use this is another perk. Don't use the top of the hammer, use the handle, because they stop each other, they sort of lock, and you don't slip. So either do this, or you can use the barrel. You put it on top, and then use the barrel and tap it in. Literally, then you feel that this is between the disc base. Most of the time, disc is collapsed, and it provides some pressure on that, and you can feel that. If you barely can move that, this is a 1 centimeter tube. So if you barely can use that, move that, your cage is going to be 9 and 10. But if you can barely move it, it's usually 11. If it's looser than that, usually you will use cages 12, 13, 14. But now this is in place. You have created a safe path from the skin to the disc base. And now we are going to use the series of 2 to do our discectomies. Now I'm going to go the steps of what I use. There is no orders to that, and just you have to go by feeling about what feels right. But exactly that's what it is. This is the most important perk. This job is done by feeling. You feel when your metal is on the bone, you feel a high frequency vibration on tip of your fingers. So then you know you're on the bone and the cartilage is gone, because otherwise it just smoothly turns, whereas when you're on the bone, you feel that there's a high frequency vibration. Sometimes you can't even hear it. Now, at this point, get lots of pictures. Make sure that the tip of your tube in the AP has passed the half of the pedicle, at least half of the pedicle, but not more than the entire pedicle. And in the lateral, make sure that you are half a centimeter to a centimeter, half a centimeter to a centimeter in. So half of the pedicle to entire pedicle in the AP, and half a centimeter to a centimeter in the lateral. This is the proper positioning of this. But then you get an X-ray, make sure that it's not more than that in, and then get lots of X-ray when you're doing that. So you go in and create a path, a cavity, and these lines are 27, 30, 33. And then once you create a cavity, you can as well fan it a little back and forth to make that cavity bigger. But then by then, you know actually what length of the cage you are going to use, because 27, 30, 33, on the X-ray you see what is the proper depth for you. And at this point, practically the next step is using discectomy tools. These are the tools that we use for that. First of all, what we call fanning curette. Here, it fans up. When you pull this together, it fans it out. If I push that, that can jump back. This is still open, but once you pull it back into the tube, it closes up passively. And here you see as well the numbers that shows how big your cage should be. Sometimes it's useful, but most of the time by how this moves and turns, I already know what cage size I'm going to use. Very important thing. This turns only clockwise. Otherwise, if you try to turn it counterclockwise, the fans may separate and then you may break it. And it have never happened to me, but theoretically it's possible to break this if you turn it counterclockwise. So always clockwise. So what I do, I go in, I aim it at the disc base, like I aim it like this, and then open it, and then turn it few times, then open it a little more, then turn it few times, and open it a little more, and you can fan it as well. So practically you're loosening the pieces. Then I use pituitary, and I use it in this fashion. I already go in and about to come out, I open it and take bites in all quadrants in here, and then I use it backhand, and then again take quadrant. Very useful tool. It just takes time to get used to it. But once you get used to it, you never do old-fashioned discectomy ever again. Then there are few things that as well are important to use. So you use the drill, fanning curette, take the pieces out, and this is a very useful tool. Now, sometimes it has to be obviously put together properly, and maybe we make another video to how to put it together right after this. But for the surgeon part, this is like, first of all, it should be put together that this window here is where the curve comes out. Sometimes it's put the wrong way, it goes the other way, but you will know it on the X-ray. So literally, you put it through the tube inside of the disc base, and then you open it up. And as you see, when you open it up, it goes in the direction of the window here. And now I put it all the way up, and this is now a perc. So it's all the way out, and then use my finger until it closes, then bring it back here, so that only part that is useful comes out and not anymore. And then what you do with this motion, you literally loosen the disc on both sides, and again you feel the high frequency vibration on that. Now, I'm pretty aggressive with this and go around and sometimes even move around. If it let me move around like that, then once I'm done with one side, this is another perc. I pull it back, turn 180 degrees, then I come out again, and it goes the other way, and do it this other side as well. Then you have to stabilize it, then you can pull it out. Sometimes this can lock and so on. If it locks, obviously use another one, but it's as well possible to use it without pulling it back. Then this is what I do. Try not to do that, but if that's a rescue technique, that this is already in, I put it in, you look at the direction. I push it in and do it that way, okay? But then you have to control this very clearly. But this is a rescue technique that sometimes, here again, in the direction, push it in, turn the direction, comes out, okay? So now you have loosened it significantly. You go back with the pituitary, take more pieces out. And this is a really, I love this instrument as well. It's what we call rotating curette. I'm sorry, the articulating rake. And I go into both directions where the end plate is. I go in and do this. And sometimes I rest my hand on the patient and then I do this action both in the forward and backward. And then I loosen this and then again I go with the pituitary, take the pieces out. Sometimes truly big chunks come out. And then at this point, once I'm, again, by feeling I'm comfortable with the end plate preparation, with the discectomy, I use tricalcium phosphate soaked with bone marrow. In this, I go inside of the tube, and then this is directional. You can direct it whatever direction you want to go. That's another perk I'm going to tell you. Often, I on purpose try to break a little through the end plate, and you can do that with the rake or with the pituitary. So literally, I penetrate the end plate, and it can bleed, but then you will pack it with tricalcium phosphate. It stops right away. But then I create truly a pathway, a highway from one bone to another. That is partially why our fusion rate is 98%, because I create a true path from one bone to another. It's okay because it's in one place, your cage is going to go around it. So I try to poke in the middle of the bone. Then at that point, you have done your discectomy, you have put your material in. Then your K-wire goes in. I rest the K-wire in the tricalcium phosphate that I have packed in. Now here comes putting the cage in. Now, the cage should be put properly together in smaller cage, not in big cages. Sometimes it's possible to put it the wrong way. This is the correct way. The windows toward where they go to the end plates are in the direction of the cross. But sometimes it's possible that somebody put it the wrong way, and in a smaller cage, this is sometimes actually possible. So if it's the wrong way, you just have to correct that. You see, this is locked here. You just have to pay attention to that it's in the correct way. Same thing. You go in, you pass through the skin, don't fight the skin, to pass the fascia with the hammer. Make sure at all points it's aligned. The K-wire and the cage and the handle are aligned. If there's an angle, you're going to bend it. And once you pass the bone, you feel it. You may get a signal, neurophysiology signal, when you're passing it almost always after 10 to 30 seconds, it subsides. But then when you're on the bone, first, again, look at that. I don't use the tip of the hammer. I use the handle here because they lock into each other and stay safe. I make sure the tip of my hammer, tip of my cage is truly digged into the capsule. Then once I'm comfortable with that, on the X-ray, I pull it out and bend it over this groove so that it's secure. And then, but at this point, when I bend it, it has to be less than half of the vertebral body traverse. And then I use the big hammer. This is the point you have to just get it in. No love tapping. If you are hitting it more than 3 times, you're causing more energy that get transferred, and probably one of the factors with the rate of nerve root injury or nerve root irritation is number of the passes we do with your probe. And second correlation is with how fast you get it at this point in, because the tip of that has to get in. The tip of that, it would open up the space. This is the point, that the critical moment that it should go fast. So once you put it in, once you dig it in, take the big hammer and just ram it in. There's no way around that. If you're hitting it more than 3 times, you're literally, if you have a high energy impact and it quickly goes in, it opens up the space. But when you're doing this love taps, the energy gets transferred through the surrounding tissue. And that is one of the factors correlating with nerve injury that I have found out. So you put it in, then once the half of the cage is in, actually the K-wire can come out, and then you do final positioning. And you can as well, once the half of it is in, you can as well change somewhat the angle and put it more in the front or to the other side and so on. But as well, I put it sometimes eccentric on one side or another to correct for scoliosis. But then you literally disconnect it. Now you remember I told you that sometimes, this is not a perk, that it's put the wrong way. You think you're in the correct way, but you are not. With this cage, only with the titanium cage you can do that, and never try that with the PEEK cage. Once you are in, you still can overcome the force and turn it the correct way. So inside. I used to go when I go through the cabin triangle, I used to go with the bigger cages this way and turn it then automatically to have a smaller profile. I found that has really no effect on any kind of outcome. So these days I just go the way I'm going to go in because it opens up its own way. But you have to pass that segment really quickly. Now, once this is in, obviously then you disconnect and take the inserter out. And at this point, if there is a need to go back in and reattach that, there's a hole in the skin and there is a memory, path memory. You just put, if you need to go back in, you take the dilator, you just let the gravity do the work. If you push it, you create new path. But if you let the gravity just find its way, it finds its way through the tissue and surprisingly well, finds the cage. You feel the cage, you can then put a K-wire over this into the cage and then take this out, put that back in if you want to reposition, or if you want to take it out, you can here disconnect that. You can just put that back in, re-engage the cage, and then either you use a mallet that it has a slit in it and tap it out, or if you don't have that, you can just put a K-wire coker here, and then coker on that, and then you can tap this out. And another thing that sometimes you notice in another perk, that when you're trying to get into the disc, sometimes there are osteophytes. You remember at the beginning? These are not the perks of this. At the beginning, you have the sleeve, and you have the sharp end going in, but there's an osteophyte in your way. You see the trajectory is right, you're right on top of that, but there's an osteophyte holding you back. What I do is I hold this, I put just 2 to 3 millimeter, maximum 5 millimeter of that. Look at, I'm resting it on my hand. I use the hammer, either this side or this side, and I break through the osteophyte, I put it in. Sometimes even I use 2 coker, one coker holding this, one coker holding that, and but by doing that, I truly break through the osteophyte. On the X-ray, in cases like that, you see a deflection. You see that the tip of that is deflecting on the bone. That is absolute proof you're in the disc space, and you're not in a funny position. But make sure that in the AP and lateral you're advancing to the same amount, like not past the midline in the AP, and in the lateral you are just a centimeter or so. Except you're planning to put the cage completely on the other side. Let the cage go where you want to go, not you follow the cage. So now let's talk about actually at this point, talk about the perk of some of these instruments. Let's start with this. We talked about that if this sometimes jams and how to use that. We talked about that this should be the direction of the loop, but sometimes it's possible to put it the other way. Okay. you feel that there's a weak point in this. You feel that when it breaks, and that's always breaks right here, which is very safe place because this is the nitinol, and the other side is secure, and then you can still with force hold the thing, the tube, and then just with force pull it out. Okay, the way it puts in, it get put in, is that literally you have to disconnect this, and this is how it's put in together. These plates, they come in this form, and make sure you see that in both ends, and you see here that there is it's sometimes hard to see, but there is a groove here. This goes toward the groove. You go in on both ends, here and here. You put that in, and then you turn it this way. And this is where it breaks when it breaks. 100% of the time when it has happened is there, and sometimes I abuse it. I sort of aim it for that, because then I know I have used the maximum capacity of this. So, and this is again the groove, you feel it, the groove here. It goes in the direction of the window here. Before it comes out here, actually you have to put this in. And then you put it in, and then you turn. At this point, you can attach the grip. Then it helps you to pull it in better. When you are in, do not turn this, because if you turn this, it just does this, the tip turns around. If you use this, you have to hold this steady and turn the handle, turn the knob here. And again, if it blocks, then just keep it open and use the other trick. So now regarding this instrument, we talked about that it opens actively, but it closes passively, meaning like that. And if it's in the tube, look at that here. It opens up, it won't come out. But if you literally push this and bring it back, now look at the tip, it closes passively and comes out. Let's talk about that. To put it together or take it apart, this is the knob for that. You see, this is flush, this is not. This is what actually let you come out. And this is what's holding it back there. Sometimes it wears off, and when you try to open to the maximum, this is another perk important information, sometimes it just ejected, no problem. You just come out, then this stays in, and then this passively closes, and you just take it out. Either they give you another one, but this corner here is sometimes worn, and that ejects when you're trying to use it. So to put it back, you go this way, and you push it in here. Here, it goes, you see that is the direction of the window. You go back in.
It's the other way around, flip it 180 degrees.
It goes 180 degrees.
So the little notch has to be facing down. If,
oh, okay,
if the
well, here you are.
The buttons are facing up.
Okay, so the notch goes down here, and then, oh, there's another notch here, okay. So then it's engaged. Yeah, this is the notch, okay? This is the thing that goes. So again, I'm pushing it up here. This goes the direction of this one where not the window is. Okay, so here, and it engages, okay? So, then actually, so far so good. Now, another thing is that I'm going to show you is the decorticator itself. If you are going to use that, the decorticator is used this way. Obviously, when you put a K-wire in, already you have a K-wire inside of the pedicle here, right there. You have put the jam sheet, you have put the K-wire, and this is the decorticator. Absolutely make sure this is locked in, because if it's not, there is a lip here that will hold you back on the tissue and just rip it apart. But if you do that, it's a smooth surface that slides and opens and dilates. Now, obviously, the direction, this is eccentric. You see there's a groove here. This is where the K-wire goes in. There's a groove there. And the direction of that has to be, the facet is always superior and medial to the pedicle. So that's all what it is to it. You put it in, make sure that you don't change the angle. You go down and you are there. And once you are on the bone, that is the time you let this go and drop in. And then with this motion, you grind the surface of the facet. You see, it's very aggressive. It's already taking the facet apart. And once you do that, have done that, you have opened up the pores of the facet on both sides. You take this out, drop just a little bit of tricalcium phosphate, then use the temp, the flat piece, same way. Make sure you don't put any tricalcium phosphate behind this, because you need to be in that direction, and then you put it in again, you tap it in both ends, and then you hold this, you come out, at the skin you pull it and take it out. Now, when you're doing that, sometimes it's possible to bend the K-wire. And there are few methods of it's rescuing it. And you can even rescue the really sharp bend. But if the bend is literally more than 45 degrees, so if the K-wire is bending less than 30 degrees, what you can do is when you put your screw in, let's just imagine this is the screw. I have put the screw in and I'm going in. I'm hitting the bend right here. This is what I do. Again, I hold the screw handle, I pull this, and I adjust it on the X-ray that it's as aligned as it can be. And then either I pull it out or I roll the bend over the screw handle, and that sort of pull the bend in the screw. If the bend is more than 45 degrees, you are much safer to put a jamshidi back in. As a matter of fact, if the bend is more than 35 degrees, put the jamshidi in, down to the bend, literally then roll this over the jamshidi to pull the bend inside, and because the inside of that is bigger in the jamshidi than in a cover, and then put the jamshidi back in. Take your K-wire out, put a new K-wire in, and here you are. Here you go. You can rescue that by doing that. So this is more or less what I have. Obviously, once you put the cage in, you either use this or a coker to open up the knob. Sometimes it's really tight. But this is so far what I got. What am I missing, Mitch?
I think you covered it.
Okay, thank you. Stop it.